Sorry, I went off there. For those in Zambia, it's because we are using VPN in China. Certain do not work out in China. There is no Google, no Facebook, no WhatsApp. In fact, even Zoom is not a platform that is allowed in China. So you need to go around certain things. Nonetheless, we will move on to the next speaker. In this case, we'll be moving to Professor David. I'm sorry, Prof, I was not there to give an introduction, but I asked Antonio to do that. So Prof. David is actually an associate professor of surgery in the Nuffield Department of Surgical Sciences, University of Oxford. He is the clinical director of high intensity focused ultrasound unit at Oxford. And he is a governing body fellow of Green Templeton College in Oxford. He is the current president of International Society of Minimally Invasive and Virtual Surgery. He's an associate editor of the British Journal of Urology International e-learning modules from 2015 up to now. You may wish to note that he is actually an honorary consultant at the Oxford University Hospital. And more recently, he has been involved in renal transplantation for tumors in solitary kidneys, where he was involved in setting up Oxford as the national referral center for these complex cases. He is also an established trainer of doctors at Oxford University. He teaches in the urological department. So Professor will tell us about the experience at Oxford University. Professor David.
Thank you very much.
Yours.
Thank you very much. If I can share my screen. So can you see this?
Yes, we can, David.
Yeah.
Yes, Prof.
So there we go. So I have not visited Zambia. I would love to visit it. Let's just move this on. But I did visit South Africa with Raymond a few years ago, and those were two of my pictures that I took in one of the game parks. So I would love to come and visit Zambia at some stage, but here I come from Oxford, and this is the systems that we have had in Oxford. I'm not sure if whether you, let me just see if I can get rid of this. I'll put it down there maybe for the moment. So we have had links with Chongqing since about 2000, for 20 years. This was the first unit that we built, which, although it looks very small, was actually the first purpose-built HIFU unit in Western Europe. And we had this JC200 system. This is our new cancer center at the Churchill Hospital, but also has radiology department where we have the JC200. And like Rosie, we look to William Osler, who ended up in Oxford, having been trained in Canada, and then was one of the founding fathers of Johns Hopkins in the United States, but he ended his life in Oxford. And we've heard how ultrasound works, so I don't need to spend time about that. Obviously, most of the time we're looking at the image, but with HIFU, we're interested in the absorption. If you put the power up 10,000 times, you can kill cells. We have done quite a lot of different trials in Oxford, looking not only at fibroids, but these other things, which I'll talk about in the next few minutes. And we have had clinical treatments funded mainly by trials. I'll talk about some of these. And we also have a big experimental section led by Professor Konstantin Kousios, who is head of biomedical engineering in Oxford. So we have a very good collaboration with preclinical as well as clinical work. We started when in the early 2000s looking at liver and kidney cancer to get the Chongqing HIFU JC machine CE marked for Europe. Looked primarily at the safety and toxicity and the performance of HIFU, looking at both liver tumors and kidney tumors in 56 patients. Some we treated the tumors and looked radiologically. A few we treated the tumors and then we resected the tumor that had been treated and looked at the histology. And in the same way with the kidneys, both some surgery where we removed the kidney after treatment and some just looking at the radiology. A few issues with skin burns, but very, very few side effects. And here is our early team. All of us are a little bit, especially me, a little bit older now. And this was the first patient ever treated in the West. She had metastatic liver cancer and died shortly after of her disease, but we allowed us to treat her liver tumor. This person, David Weil, very sadly died of a brain tumor a number of years ago, but was instrumental with me in setting this up. So we wrote up our early experience in the British Journal of Cancer, looking at the safety and feasibility of HIFU in a Western population. And as a result of these studies, the machine was CE marked in 2005. We then had various other kidney trials looking at the ablation of a large mass and then histology and small renal masses, then histology and small renal masses, and then histology. We also looked at laparoscopic HIFU and various translational studies as well. And on one of the subsequent renal treatments with 17 patients, 15 completed their stay, 1 went on to surgery, but 14 of the 14, 10 remained under surveillance with good treatment. 4 required other treatments, 1 RFA and 3 radiofrequency ablation and 3 surgery. But here's an example of an early one that we did. I think you can see a contrast uptake here, 12 days after HIFU, lack of contrast uptake, and 6 months and indeed a year, and indeed 5 years later, there was still no uptake in that area of tumor that had been treated. So it was had been totally ablated. A colleague with a different system looked at laparoscopic HIFU. Of course, that is invasive, but we did demonstrate that it would work. And we did laparoscopic HIFU on this patient and then took the tumor out and showed the area of ablation. But of course, laparoscopic HIFU is invasive and we have not pursued that. One of the problems with kidneys, or the 2 problems basically, that we found are ribs that can get in the way of treatment, but also perinephric fat, the fat around the kidney. And here in this CT scan, all this dark area is fat around the kidney. And one of the reasons why it was not working so well with kidneys was, we thought, because of the absorption of fat. So what we did is we looked at 10 patients who were undergoing renal cancer surgery, and we removed perinephric fat. And as fresh tissue, we put it in a saline water bath at 37 degrees centigrade and performed experiments on it fairly quickly, 10 times with different thickness of fat between transducers. And this is what we found, that if the thickness of fat was 2 centimeters, then the intensity of output went down to 58%. And as the thickness of fat increased, then so the intensity of output decreased down to about 1/4. Now, here I was also involved for a while in renal transplants, and we had a couple of patients who had tumors in a renal transplant. Here's one. And we treated 2 of these with HIFU. And you may be aware that if you do a transplant on a patient, when you're transplanting the kidney, you remove all the fat from it and you put it in the iliac fossa so that it's not underneath the ribs. And that meant it was much easier to treat. And here's a post-treatment, which I then removed this tumor from the kidney and found that everything had been completely ablated, just apart from a slight rim of a tumor that was left. So that was much easier to treat. In terms of fibroids, you will all be aware of this, so I don't need to talk about this, but here is one of the cases that we treated. And I'm sure Raymond, who has much more experience of fibroids than we do, will tell you about this. But here's one case, and you can see how after 2 weeks and after 2 years, very good ablation of this fibroid. And we were involved in helping to write up and direct this 20-center study. And although all these cases were done in China, we were very involved through the Surgical Interventions Trials Unit and the Department of Surgery in helping to construct this paper. And this was a very important paper. It was very important also for us in the UK to get this technology NICE approved. And we looked at these various issues in China, and basically 1,300 people received HIFU, 472 hysterectomy, 586 myomectomy. And the quality of life improved more rapidly after HIFU. And the advent of major adverse events were much less in HIFU than in the surgical cases. And many of these patients came from quite far away, which was why the hospital stay for HIFU was 4 days, as opposed to these other days. But I think most people who are treating fibroids with HIFU can be done as a day case. I think that's what Chongqing are doing now. We, when we were starting this, just kept them overnight just to be absolutely sure that everything was all right, but none of them had any problems. And this, as Rosie has already said, was written up in the British Journal of Obstetrics and Gynecology, and a very important paper, really, especially for us in the West, for getting this NICE approved. We did an earlier trial just on a few patients, much fewer patients, but this was our Oxford experience with improved symptom scores during the 2-year follow-up, and fibroid volume and reduction rate also during the 2-year follow-up. And of course, unlike radiotherapy, if the symptoms recur, or if it's a very large fibroid and you can't treat it in one setting, you can always treat it on a subsequent occasion. There's no limit to the number of treatments that you can give. So as a result of that work, we presented this work to National Institute for Clinical Excellence, and that was accepted in 2019, and we're going to go back to them next year after 3 years, just to we have to report. Obviously we haven't done that many cases during COVID, but we will see if we can just continue to get that approved and extended. So prostate machine, there are no Chongqing machines in clinical use at the moment, but the prostate machines that we have been using French ablatherm and sonoblate for transrectal prostate, and the increasing number of results for this show that the effect is as good as otherwise localized treatment. The issue with prostate cancer is that most people die with prostate cancer rather than because of prostate cancer, and mortality is not a useful outcome due to the nature of the disease, which is often a very long-standing one. Certainly, if treatment is possible, then even if you don't treat, the long-term risks of death are very low. And it's been shown that if you're suitable for treatment, then it's only likely to make a difference after about 15 years to mortality. Some people present with extensive metastatic prostate cancer, and they're not suitable for primary treatment anyway. So those that are suitable for treatment, whether you treat them or not, are going to last quite a long time. And if you treat them, the benefit is only shown after about 15 years. This is some patients with sacral chordoma that we treated. Sacral chordoma is a locally invasive and very unpleasant disease, not officially a cancer, but here was very nasty localized growths in the sacrum. Here was somebody who was unable to sit down because of these growths in the sacrum, and first treatment, we ablated one, second treatment, ablated the other, and this took away their pain and made them able to sit down. And again, potentially you can treat that later on if it recurs. This was written up in the British Journal of Neurosurgery in 2017. We currently have another ongoing trial for sarcomas, which has just been funded, which we have just started. This is a very interesting type that we are doing, looking at targeted drug delivery. And this is done with my colleague Konstantin Kousios. And in fact, Paul Lyon, who's a trainee in radiology, did his PhD on this work. And this is using HIFU in a slightly non-focused way to heat up a tumor. And what happens is that if you take liposomes, which are a bit like butter, so liposomes are stable at 37 degrees centigrade, but they break open at 42 degrees centigrade. And you can take liposomes and you can put a cytotoxic drug, doxorubicin, into the middle of them. And as I say, these remain stable at body temperature, but at 42 degrees centigrade, the drug is released. So what happens with this is that we were looking at targeted drug delivery for liver tumors. And this was the first study that had ever been done in humans, in man, looking at safety and also the viability and the radiological response. So what happens is that you have a patient with a liver tumor. These were secondaries from, mainly secondaries from colorectal cancer. And then you take a biopsy of it so that you know what the histology is. And then you can inject, you can measure the temperature and take the biopsy. And then you take this, what's called thermodox, these liposomes with the doxorubicin in, and you inject them peripherally into the circulation. And then you take a slightly non-focused beam and you heat up the tumor to about 42 degrees centigrade. And then what happens is that you, the tumor, as the drug goes through the tumor, it breaks open, and you get targeted drug delivery, and you get 2 to 9-fold increase in the tumor, intratumor thermodoxorubicin. And here you can see various tumors, and one was chosen, which was heated up, and after treatment, 6 days after treatment, there is no take-up of contrast in that. And here again, another demonstration just showing how after treatment, 2 weeks after treatment, you have targeted drug delivery, and it increases the dose in the tumor by about 8-fold to what just ordinary peripheral cytotoxic drugs do. And this was written up in the Lancet in Oncology in 2018. And we have just started a pancreatic trial looking both at targeted drug delivery and ablation. This was an early treatment that Professor Feng Wu, who's been with us for the last 20 years, but was intimately involved in developing HIFU in China in the 1990s, looked at 8 patients with unresectable prostate cancer and abdominal pain. And although this doesn't cure the cancer, it can delay the recurrence, but also it cures the pain. And with it's often difficult to control pancreatic pain even with opioids, with morphine, but targeted drug delivery with the HIFU did stop the pain. And here's one that we did in Oxford. It's slightly difficult to see, but I think you can see contrast uptake there and lack of contrast uptake after treatment. I just finish off with this quote, which I think is, I'll read it out to you. It's a very famous quote by Theodore Roosevelt that you may know, but I think that with HIFU, it is the people who are actually doing the work that sometimes we get criticized for doing it by people who are not doing it. But I think he was, when he said this, it's not the critic that counts, nor the man who points out how the strong man stumbles or where the doer of deeds could have done better. The credit belongs to the man or woman who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs and comes short again and again, because there is no effort without error and shortcomings, but who does not actually strive to do the deeds, who knows great enthusiasms and great devotions, who spends himself in a worthy cause, who at the best knows in the end the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who know neither victory nor defeat. I think that is a very good basically conclusion for all those who've been involved in HIFU over the last 20 and more years. It's some technology which I think is going to grow and grow over the next few years. And we're very fortunate in Oxford to have had a great team who have all been very enthusiastic about this over many years. And certainly we find in Oxford that the interest and the indications and the technology is growing day by day and month by month. Thank you very much.
Thank you so much, Professor, for that passionate presentation. I think this is what was missing in the last meeting we had with the Zambians, especially that we also invited the oncologists to attend.